Dr. Cindy, and then we'll bring her on. All right. So Dr. Cindy Duke is a highly accomplished physician, entrepreneur, blogger, content creator, and influencer who writes about issues as they relate to life, health, and business for women. Dr. Cindy's keen eye towards issues affecting those with goal health, within the goal health diaspora is informed by her own immigrant upbringing as a single mother. But also what I love about Dr. Cindy, she does so much on social, from her podcast to just how she also posts and really represents for Black women in this space. That she really uses her platform to really debunk myths when it comes to around fertility, especially around endometriosis and PCOS, and a lot of the conditions that can affect Black women. So I would love to welcome you all. Welcome Dr. Cindy to up here. I'm gonna let her get Yes, I'm gonna let her get signed on. All right, there she is.
I figured it out.
Yes, ma'am, you are here. How are you?
Well, how are you? Thank you for having me.
Thank you so much. I'm so honored that you're here. You were in the comments commenting with the ladies as they were asking questions. So obviously, I really want to debunk some myths with you, because we have all the myths when it comes to being diagnosed with endometriosis and PCOS, because it takes so long for a lot of women to get diagnosed, especially Black women. Right. So let's start out by debunking some of the myths about endometriosis and PCOS. Can you explain really what it is, what is PCOS, what is endometriosis, and why they are so difficult to diagnose in Black women?
Yes. Well, I would like to start off by saying they're not actually difficult to diagnose in Black women. People just haven't been doing it enough.
Gotcha.
And I really am excited to be here to talk about that, because, on average, it takes up to between 6 and 8 years for Black women to be diagnosed with endometriosis, even though they've been suffering for so much longer. So let's start with endometriosis. Both endometriosis and PCOS affect at least 10% of the population. And we're saying at least 10% because predominantly most of the studies that have been done looking at these two disease states have focused on women who are not women of color. And so we don't really know what the true incidence is in Black women and other women of color, but it's at least 10%. Some people say it might be up to 20%, which would mean 20%, right? Of our populations are struggling with this. But endometriosis is really a chronic pain syndrome that can start as early as our teen years, shortly after we enter puberty. And it, over time, progresses such that the pain can get worse and the damage that it's causing can get worse. It's really what we call an inflammatory disorder, in that it leads to a lot of inflammatory responses in our pelvis, so that our body is trying very hard to repair the damage that's happening from these inflammatory chemicals. And that in turn, the attempt to repair the damage leads to damage to like our fallopian tubes. We can have scarring or tubal factor blockage. We can have scarring that leads to ectopic pregnancies from endometriosis. We can have there's a cousin to endometriosis known as adenomyosis, which I like to describe it as endometriosis, but within the womb itself, the walls, the muscles. And that recurrent, repeated inflammation can also lead to difficulty with getting pregnant, implantation failure. So those patients with biochemical pregnancies, there's more and more evidence suggesting it's playing a role there as well. We know certainly in the world of fertility, when we do IVF, patients with adenomyosis have a harder time with achieving pregnancy in terms of implantation without treatment for the adenomyosis, for example. And so it's really important to know what endometriosis is. In terms of the science behind it, we describe it as the presence of cells that are normally supposed to be in the lining of your womb cavity now being elsewhere. So they can be within the muscle instead of just in the cavity. They can be outside in your pelvis, sitting on the ovaries, sitting on the fallopian tubes. We have seen endometriosis in the lungs, meaning those cells have traveled all the way to the lungs, for example. And so it can really cause a lot of difficult things that lead to chronic pain, pain with intercourse, lead to such difficult pain if it's affecting your nerves that some women have to stay home for certain times of the month because it's so painful. And so it's really important to talk about it, identify it, and know to look for it early. There's also a certain degree of genetics involved. And so if you are a woman or family member who's had really painful periods, chances are higher that your daughter is going to be born and develop endometriosis as she goes along, which means you should be on the lookout for it. I think for a long time, especially amongst, communities of color, communities where we're very much also attuned with our faiths and our religion, many people have used religion as an explanation for painful periods by saying, well, that is the pain we pay, the price we pay for Eve's original sin. But the truth is that really diminishes what most people are feeling when we go down that route by saying that, because periods shouldn't be so painful that they're keeping you from being active in your everyday life.
Yes. So another myth is that people who have PCOS, they can't have PCOS because they're skinny, or they can't have endometriosis because they have regular periods and their periods may not be painful, like you mentioned. So, but for both of those conditions, another myth that I would love for you to debunk is that you can't get pregnant naturally and you have to seek fertility treatment. So can you debunk those myths for us?
Yes, and I'm glad you brought that up because I didn't actually define PCOS. So PCOS is polycystic ovary syndrome, which takes on a constellation of presentations in different women. And the same goes for endometriosis. So the big difference between endometriosis and PCOS is endometriosis over time leads to your egg numbers falling because it can have such a negative impact in terms of the inflammatory chemicals that it's making. It can cause your egg numbers to drop faster than they would for someone who doesn't have endometriosis. Whereas PCOS, those women generally tend to have more eggs for their age compared to other women of the same age. Now, there are a couple big myths that we must debunk, like you pointed out. First one is there's some people who believe you can't have both. That's not true. You can have endometriosis and PCOS. You can have endometriosis, PCOS, and fibroids. Gosh, it's the worst. But you can have all three. The big myth, yes, is, and this is one I fight very hard to break because it's so ingrained now in not just society, but amongst physicians and general practitioners. There's this belief that if you have PCOS, you're infertile in that you cannot get pregnant on your own ever. As a result, it's not uncommon to meet someone with PCOS who tells you about their miracle baby because doctors told them they'll never get pregnant, which was wrong to begin with, and then they conceived. Now, some women with PCOS can have difficulty conceiving on their own because they don't ovulate, meaning they don't release an egg regularly. And, somewhere between 1/3 to 40% of PCOS women will experience that anovulation. For some PCOS women, that anovulation, meaning not having ovulation, is year long, all year. They go years without a period, years without ovulating. For others, they ovulate some times of the year, but not others. For some, their ovulation with their PCOS is actually regulated by their body weight, meaning their brain has a special switch that recognizes when you have a certain amount of body fat. And if you exceed that percentage of body fat, you actually stop ovulating. And then if you lost some weight, and so you'll talk to a woman with PCOS and they'll say, oh yeah, my periods were irregular, then I was working out or I did so-and-so diet. And of course, what they really did was change that body fat percentage, which triggered the switch, to help them ovulate. So that's one of the big myths is, yes, you can have regular periods if you have PCOS. Not everyone with PCOS has irregular periods. And at the same time, not everyone with irregular periods is now infertile for life. It means you have some difficulty conceiving and you may need help releasing eggs if you're on a special time crunch, but you don't necessarily have to see a fertility specialist, although many end up seeing the fertility specialist, if I'm being honest.
Yeah. So how do, same question I asked Dr. Tamika, is just about us showing up for Black women and how we make sure that we're asking the right questions to our providers. So how do we continue to advocate for ourselves when it comes to our overall health? And then if we want to seek fertility treatment based on our conditions?
Yeah. I think that's the key word, advocacy. And for so long, we were told that we were being difficult if we were advocating for self. And so it's really important to emphasize and reiterate that it's okay to advocate for yourself. And if your healthcare provider is not on board with you asking questions about your health, asking to dig deeper, then maybe that's not the provider for you. So that's the first way I support Black women, is by, like Dr. Tamika said, encouraging second opinions. If you feel like you've tried to talk with your provider and they're dismissing you, if you feel like you've come to your provider with a legitimate question, and I have to be honest, I think every question is legitimate. There really aren't any stupid questions in medicine. And that's because you know your body. I know a lot about how your body works, but everything I know still can take different paths when it comes to your body in terms of your body's circuitry. So it's important for us to hear you. It's important for us to talk with you. I have many patients who have endometriosis who are not currently trying to get pregnant, but would like to preserve their fertility in the best way possible, meaning trying to diminish the amount of damage endometriosis can cause to their reproductive organs, such that when they come back later and are ready to start their families, their bodies are as healthy as it could be if we've suppressed the endometriosis. The same goes for PCOS. When I talk to patients, and I have a big population of teenagers with PCOS, is I like working with them from that early age because I want them to be aware of what PCOS means for them. I want them to hear that PCOS doesn't mean you cannot get pregnant spontaneously, because I think that's one of the more common themes out there as well, is, well, I have PCOS, ergo, I can't get pregnant spontaneously, therefore I don't need contraception. And that's not true. And so if you're not planning to be pregnant right now, we need to talk about what that means for your health. PCOS, of course, when we diagnose it, we're looking for 2 out of 3 big things. And so with PCOS, we're looking for any of the 2 out of 3. You don't have to have all 3. First and foremost, you do not have to have polycystic appearing ovaries to be diagnosed with PCOS. But the 3 things are history of irregular periods. And notice we say history. So that means even if someone is now maybe 35 and their periods are normal, if there was a time in their life where their periods didn't come on its own and we couldn't find another reason to explain it, that might be part of your PCOS picture when you were younger or when you were at a different weight. We look for evidence of what we call elevated androgens, meaning testosterone. And so that's either higher testosterone on lab testing or clinically, when we looked at you and talk with you, do you have evidence of high testosterone, which would be acne on the face, chest, back, lower abdomen, or unwanted hair growth on the face, chest, back, or lower abdomen.
Good. Some questions are coming in. I'm gonna ask one last question and we can take the questions in the comments. But I know that there is not like an all-purpose approach or treatment to endometriosis or PCOS. So how can we overall, when it comes to any of the conditions, manage these factors and alleviate symptoms through lifestyle modification and dietary change. You mentioned about exercising and changing that fat percentage. What are some other things that we can do now, like today, to help alleviate symptoms of endometriosis, PCOS, uterine fibroids, heavy periods, so that we have a better chance of conceiving naturally?
Well, some of the things I talk about, I do emphasize healthy weight, because I know, especially as Black women, that's a tough conversation, because just our body types, our body frame, culturally, what we consider to be healthy body shapes tend to go against what medicine tends to say, oh, this is a healthy look or healthy. So that's not what I go with. I try to talk to patients more about healthy activities that keep your heart healthy, keep your body's hormonal system, which are chemical messengers, going in a healthy way. And so definitely, even if you're working out, even if you're someone who's at your goal weight, we talk about body fat percentage, because I certainly have some patients who have trouble with ovulation simply because their body fat percentage has fallen way too low. And so we know that if your body fat percentage is somewhere under 12%, that's when things start going awry with ovulation signaling from your brain to your ovaries. In terms of healthy foods, there's more and more data to support looking at what you're eating, looking at what you're storing your foods in, looking at what you're cooking your foods in, and how you're heating up your food. So what I mean is there are a number of environmental factors that do play a role, a negative role, in our fertility and in actually either blocking ovulation or actually causing our eggs to die off. And so we talk about, an anti-inflammatory diet. So looking at the foods you're eating, for some people, especially those with like endometriosis and some of our PCOS patients. And notice I'm saying some, because there isn't a silver bullet for everybody, unfortunately. Mm-hmm. But some foods are triggers for some more than others. And so we talk about an anti-inflammatory diet, which really means looking at your dairy intake, looking at the sources of your food. So in the United States especially, a lot of our animals that produce our food and our milk are treated with hormones or antibiotics that act as hormones in the human body. And so our body and our gut might be responding to those things differently and leading to what we call sort of a general inflammation pattern that might be working against your goals for fertility. So we talk about that. If somebody has endometriosis in particular, we've noticed that with endometriosis, adenomyosis, and another cousin of endometriosis, which is known as interstitial cystitis, or IC, you can have really bad pain, and they're actually what we call special triggers to your pain in food. And so, for example, for some people, it's things like chocolate, coffee, tomatoes. For others, it's dairy or cheese, yet it's the one thing they're craving all the time. And so one of the things I do when I see my patients and we're trying to figure out lifestyle changes is I have them keep a diary. And the diary is because I want them logging the foods they're eating for 2 weeks, and also looking at the pain profile. When does your pain get worse? And that's how we start identifying some of the foods that are triggers to your pain syndrome. We look at things that relate to diet. And so for some patients, they can eat most foods normally a big part of the month, but in the weeks leading up to the period is when there are very distinctive differences, even with fibroid patients, in the bloating, the discomfort, the pain with intercourse or difficulty with intercourse. So those are sort of the big lifestyle things that we talk about. Acupuncture, yoga, these are all things that help. And we believe they help because they change, again, your hormones. And so they cause changes in stress hormone, which is cortisol, and at the same time increase another hormone that we don't talk a whole lot about, which are endorphins, the happy hormones, and serotonin and dopamine, which actually act at your nerve and your nerve endings, your pain sensors. And so those are the things we talk about and start targeting.
Yes. So someone asked, what type of procedures do you recommend for women who have fibroids and maybe trying to get pregnant?
So when it comes to fibroids, I like to say it's about location, location, location. So it's important to explain that not everybody with fibroids has to have a procedure. It's more, where's their fibroid located? What kind of symptoms is it causing you, if any? And what are the goals? So for example, someone may have fibroids, but they're tiny fibroids, 2 centimeters or 20 millimeters. I like to say 20 millimeters because I have my own patients who text me frantically because they had an ultrasound and it showed a 20 millimeter fibroid, and they're like, oh my God, 20, that's a big number. But 20 millimeter is still smaller than a cherry. So they have like a 20 millimeter fibroid, but it's sitting in the muscle, in the wall of the uterus. There's nothing we're going to do about it because it's not a danger to you. Whereas if there's a 20 millimeter or 2 centimeter fibroid sitting in the cavity of the womb, the place where a baby grows, the place where your period comes from, I may want to address that. And we want to address that for a number of reasons. So we know that fibroids, first and foremost, grow with pregnancy. And so the ones that are in the cavity, even if they're not super large right now, will grow with your pregnancy. And as they're growing, imagine your womb cavity being an apartment or a house with a fixed, size for the tenant. Well, imagine the walls of the house are actually growing smaller, even though it's supposed to be an expandable house, while the tenant is growing bigger. So a fibroid can compete with the baby that's trying to grow in the womb for space, and that can lead to miscarriage. And so certainly if someone is having pregnancy losses, particularly, in my case, when I see a lot of my Black patients, one of the things that I have noticed is many of them show up and they have a submucosal fibroid, which is the fibroid sitting in the womb cavity. And without addressing that, they continue to have miscarriages, recurrent miscarriages. And there's strong data for addressing a submucosal fibroid, which is the one in the cavity. And so that's why I asked earlier, did that patient have a hysteroscopy? Because, crazy as it sounds, I've met patients who've had the cerclage placed, number of things placed, but didn't have the cavity checked because someone didn't look in with a camera. They just sent them for an MRI or they sent them for an ultrasound. And so, like Dr. Tamika was saying, you do have to be very thorough and you have to look inside the womb when you're assessing for fibroids, especially in a recurrent miscarriage person or somebody who's had a pregnancy loss or very early preterm delivery.
Is IVF the only option for stage 4 endo and trying to conceive?
IVF isn't the only option, but it often becomes the best option because with stage 4 endometriosis, pretty much most times the fallopian tubes are involved. And so with endometriosis, and actually first with pregnancy, right, we need 3 big ingredients. We need sperm, we need egg, and we need a place for them to meet in the body for natural pregnancy. And that place is known as the fallopian tubes. Think of them as arms with catcher's mitts on the end. So the catcher's mitt is supposed to capture the egg when you ovulate, and then the egg's supposed to make its way down into the arm, and the sperm is supposed to meet it in the arm to start the fertilization, and then an embryo is supposed to roll its way down from the arm and implant into the womb. So if endometriosis is so advanced that it's now scarred the fallopian tubes, they may be completely blocked. And if they're not blocked, they may be scarred such that within the tube you have these little things known as cilia. They're supposed to help that embryo make its way down into the womb. If the cilia aren't working well because of endometriosis, the scarring, the inflammation, then that person will need IVF. And so I know for a lot of people, the sound of IVF makes it seem like doctors just jump to that, don't they? But we actually don't. We try very hard at the beginning to help you get pregnant every other way possible. But in some patients, it makes more cost-effective sense. It makes more general health sense, especially if you have scarred tubes, to do IVF.
Yes. Another question, it will be our last question before we sign off. Can cervical cysts also affect the ability to get pregnant?
The truth is most of us have cysts in the cervix. They're known as Nabothian cysts. So not necessarily, no. Most of those cysts in the cervix are actually there to produce mucus. which is to help, the mucus changes depending on the time you are in your cycle. It helps for sperm movement, etc. But if you're someone who has a cyst that's maybe growing outward or protruding into the cavity, blocking the cavity, maybe it's affecting things. But I have to be honest, I think Dr. Tamika would agree as well. It's a very rare case where someone has a cyst on the cervix that's leading to infertility or problems conceiving or staying pregnant.
Got you. Well, thank you so much, Dr. Cindy. This was awesome. You have a good evening, and we'll talk soon.
Okay, bye. Take care.
Bye. All right, guys.